I'm Liz. I'm an MS3 at the University of Miami.
Hi, and I'm Gabby. I'm a fourth year at the University of Miami. We're here with the Integrative Medicine elective.
And so today we're talking about psychedelics and the use that they've had in the recent years, plus in the psychedelic renaissance that used to happen in like the 50s and 60s. So what exactly are psychedelics? So these compounds, the word really originates from the Greek root of mind manifesting, which is really interesting because in a lot of the studies that we've come across, it's really kind of how patients describe their experience with their thoughts. And this is like naturally occurring compound that happens in fungi and plants, and sometimes can be even created synthetically. We may know some as like MDMA, ketamine, things like that.
So there are three main classes when we're talking about psychedelics. When you're categorizing them in a chemical way, there are other classes if you're categorizing them in like an effective way. So our three main classes and then like an extra bonus. So tryptamines, specifically psilocybin, which is like what we think of as like mushrooms and DMT, ergolines, an example of which being LSD, phenethylamine. Yes. An example of which being mescaline, which is like commonly known as like peyote, and then dissociatives or deliriants, which is like ketamine. And it causes varying effects on perception, cognition, and mood. And so we have like an explanation of some of the different like categories as they are in their chemical structures, and then you can see the green are ones that are naturally occurring, the blue are ones that are synthetically created, so the ergolines, LSD, tryptamine, psilocybin, DMT. Dissociatives and deliriants like ketamine we see in the hospital a lot, phenethylamines, mescaline, which is peyote, DOM, DOI, and then MDMA, which is kind of connected but kind of similar. It has its own mechanism of action, so it's considered like a deliriant or dissociative, but the mechanism's a little different, which we'll get into. Okay, so I have my speaker notes. Okay. So we can categorize the effects and the mechanisms of action of the psychedelics in different ways. So usually we're talking about classical psychedelics, they're acting on serotonin receptors of the brain. So molecularly, they act on serotonin receptors, they influence signal transduction pathways, and they're able to affect through those modes like gene expression pathways, and then on like the whole brain level, affecting like the functional connectivity and can impact whole regions of the brain. So you see like at every level of the brain, like these psychedelics are having some effect. And then if we're talking about like MDMA, which are not considered a classical psychedelic, they work by inhibiting serotonin receptors rather than like acting on them as an agonist. So talking about serotonin receptor agonists, like we can go a little bit more into how the specific like mood consciousness alterations are taking place. So by working on serotonin receptors like agonistically, they have a decreased connectivity to default mode network, like we see here, and that is kind of how we attribute the function of decreasing negative self-thoughts, and that is how we think it has some of its antidepressant or anti-anxiety effects. And then it also decreases like amygdala reactivity, another mechanism of action for antidepressant effects. Also decreasing like threat sensitivity of the visual cortex, anti-anxiolytic, decreases pro-inflammatory cytokines like TNF-alpha 6, and that is another mechanism that's kind of thought to be antidepressant quality, and then it increases glutamatergic transmission, also antidepressant. So we have ways like anatomically that we can show proof that these psychedelics are having effects, and then also kind of get into the details of why are they having these effects and what's like the chemical reactions and the anatomic correlations taking place.
And just to touch on what Gabby is saying, so we know depression is an has an anti-neurodegenerative effect on the brain. So they're actually doing quite a few studies on trying to see if using these compounds for the treatment of anxiety and depression can kind of kickstart that neurogenesis in the brains of people who have depression and are using this as part of their treatment. So it's very interesting.
Lots of good stuff coming out. Okay. So this is a recent systematic review that's talking about the use of classical psychedelics specifically, and specifically in anxiety, or depression, or both. So this is 7 trials. Much more were evaluated, but 7 clinical trials only were included for a total of 130 patients. 2 described patients with depression, 2 with anxiety, and 2 with both. They usually look at psychedelics for use in treatment-resistant depression, which is the TRD, or recurring depression. And there's also some like comorbidities. We're talking about anxiety and depression in patients with terminal illnesses, anxiety and depression with chronic illnesses, terminal cancer, and similar. So here we have our 7 clinical trials. They're all clinical trials, so it's either open label or blind randomized clinical trials, and the drugs that they were evaluating. So ayahuasca, psilocybin, or LSD. 5 psilocybin, 1 ayahuasca, and 1 LSD. And they had really positive impact. So one that I went into was about ayahuasca, which is our top one here. So these are patients with like recurrent major depressive disorder. They saw significant reductions of up to 82% when they're looking at the baseline versus 1 day after the drug was done, 7 days, and 21 days. So they see like long-term effects as well. That has like great implications for like single dosage administration. And the scores that they saw the most impact in were depressed mood, feelings of guilt, and suicidal ideation. We can see here that these were all different types of like depression scales and anxiety scales. So they looked at the affective depression inventory, the brief psychiatric rating scale, the hostile anxiety depression scale, the Hamilton anxiety rating scale. So they're all looking at like similar but different, but all previously validated scales. So here we have significant reductions at a week and 3 months, reductions at a week, 3 and 6 month follow-ups, reductions at 5 weeks after each dosing, and a final 6 month follow-up. Reductions at day 1, week 2, 6, 7, 26, and a 6.5 month follow-up. So we can really see that these are like high quality studies that show like a meaningful effect, but they are pretty low, low numbers of subjects that are included. So 130 total when we're looking at the meta-analysis.
And then for the next part, we're going to go more in detail into the Griffith 2016 study that they did on patients with life-threatening cancers and their effects on anxiety and the depression that these patients were experiencing as they came to terms with like their diagnosis. So this study was a randomized control trial that included 51 subjects. Half of them were allotted into the control group, which received a low dose, which was 1 or 3 milligrams per 70 kilograms. And then the other half, the other group, which was the experimental group, received the high dose, which was 22 or 30 milligrams per 70 kilograms of psilocybin over a 6-month course of treatment. So over these 6 months, these patients received only 2 administrations of the psilocybin. So one was at the 1 week mark, and then another one was at the 5 week mark. And so then they analyzed longitudinally what Gabby had mentioned previously, which was the Gridham D scale and the Ham A scale to see what the effects on the depression and anxiety symptoms that these patients were experiencing. So what that study reported was that the high dose group produced a large decrease in the clinician reported and the self-reporting of those patients in measures of depressed mood, anxiety. And then they also found that these patients were experiencing increased quality of life meaning, optimism, and decreases in death anxiety, even at the 6-month mark when the last time they had received the dose was at the 5 week mark of the study, which I think is quite remarkable, especially for when patients are diagnosed with the terminal cancer. And then some precautions that we found in some of the studies were that psychedelics seem to have a sympathomimetic effect, so patients can experience increased heart rate, increases in blood pressure, increases in pupil size, and increases in body temperature, but normally these didn't really go above 100 degrees Fahrenheit. Some feelings of fear and anxiety, dysphoria, and or paranoia were experienced in patients who received really high doses of psilocybin or MDMA in the studies that I found. But in patients who use like low doses or more moderate doses, these effects seem to be more mitigated. Like any other medication that we take, though some patients experience some GI distress like nausea, vomiting, and things like that. And then just something that Melissa wanted us to mention. So the risk of, she looked at the risk of seizure for patients using psychedelics. So she found that from 1992 to 2023, there have only been 10 case reports in patients who experience seizures after ingesting classical or atypical psychedelics. And then in recent reviews in the Journal of Neuropharmacology, call for potential use in monitored clinical setting, even in patients with epilepsy, particularly for PNES. And then she also wanted us to mention a few more things about that.
That's great.
So basically, epileptics have been widely excluded because of the seizure-inducing potential of these compounds, but there are a lot of people with PNES who have been seizure-free that at the review was recommending that could be a new area of research, especially in a monitored clinical setting. The article also pointed out that atypical psychedelics like ketamine would be good for epileptic populations suffering with depression. And this kind of tracks because whenever a patient has to have surgery, usually ketamine would be one of the agents that's used to induce them as an anesthetic. So it's very interesting. And then she also mentioned that ketamine is being studied as like a fourth or fifth line anti-seizure medication. So it's a perk that it has that psychedelic component to it.
Victoria's calling in.
Okay, and
I'll text her.
one other
You're there.
precaution that is interesting that a lot of the different like studies mentioned in their methods is that the mode of administration and kind of the setting that the experience is completed in is very specific. That this isn't like a regular pharmaceutical that you're going to send out in the pharmacy and someone's going to take at home. It's more labor intensive. It requires guides. It requires specialized settings, comfortable rooms, and that like the experience can be very like make or break, and that it's not going to be for every patient, every situation. And so there are some implications with that when it comes to cost, access, because it's going to be like cost intensive to have, for example, like a guide there, to have a setting in a room. Is it going to be billed as procedural? So there are like other implications to think about when we think about how this is going to actually look practically in our healthcare setting, even though we can see that it has like amazing implications for having a really great effect on people.
And just kind of continue on that, just to kind of give a shout out to the VA system because they're really kind of leading this sort of research for our veterans who experience PTSD, depression, and anxiety symptoms after they come back from being deployed. So yeah, it's very, very nice that they're able to fund this kind of research and do this kind of work so that we can apply it to the general population.
Which is actually, can we go back for a second?
Oh yeah.
So this slide.